Hi, everybody. Welcome to the second session of this meeting. The theme of this session is perinatal and childhood hepatitis simplification strategies and test everybody. As you all know, hepatitis B infection in pregnancy, its perinatal and childhood transmission is a nightmare for every mother. Though it's a vaccine preventable disease, but the vaccine has affordability issues. The diagnosis and treatment of hepatitis B during pregnancy has access and affordability issues, and many mothers are therefore lost to follow-up. Giving treatment to some mothers and denying others is also a complex decision. While every mother wants to protect her baby and therefore is looking for antivirals or the immune globulins or the hepatitis B vaccine, but all these steps need simplification. So let's hear from our experts as to what do they say about it. So let me invite the first talk on the perinatal hepatitis B and mother-to-child transmission. And this is by Dr. Po Lin Chan. And she is the regional focal point for hepatitis by WHO at WHO. So Dr. Chan, the floor is yours.
Good morning, good afternoon, and evening to all. It's my pleasure to be here today. We're going to talk about hepatitis elimination, where we are today, and on the importance of hepatitis B prevention of mother-to-child transmission. I'm going to bring you some snippets on the 2020 new WHO guidelines on the use of antiviral prophylaxis among pregnant women for prevention of mother-to-child transmission, and to conclude on some implementation considerations. Of the 325 million people living with hepatitis B and hepatitis C globally, 80% live in Asia and African regions. Specifically, on hepatitis B, the burden is substantial as well, and we have almost 1 million of people die of cirrhosis and hepatocellular carcinoma. Here is a little reminder why preventing hepatitis B mother-to-child transmission is important. Infection during infancy and early childhood are particularly likely to lead to chronic infection. And thus, we see that vaccination works. Vaccination has had successes in preventing new hepatitis B infection among children under 5 years of age. So globally, before 2000, the prevalence was about 5%, and in 2017, global prevalence was overall less than 1%. The global hepatitis control goals now have more than about 2 decades of experience. We know vaccination works, and we have seen countries reach the target of under 1% hepatitis B surface antigen among children under 5. And in the Western Pacific region, 21 countries have already reached this target ahead of time. And they have a very high coverage of vaccines and coverage of primary birth dose. But to get to elimination of hepatitis B, this is defined as a 0.1% hepatitis B surface antigen in children under 5 years of age by 2030. And to get to this target, we will need additional interventions to prevent mother-to-child transmission. Let's look at the Western Pacific region, which is leading in the implementation of hepatitis B elimination of mother-to-child transmission. The Western Pacific region has a framework on triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B for the next decade. In the Western Pacific region, 57% of the countries are already conducting triple antenatal testing for HIV, syphilis, and hepatitis B. And 30% of the countries provide antiviral prophylaxis to eligible pregnant women with chronic hepatitis B. And 24% are conducting infant case management follow-up, including post-vaccination serologic testing. The Western Pacific region boasts of a very high primary birth dose at 84% and a completion rate of true vaccines for hepatitis B of more than 95%. So this is tremendous learning and tremendous success. So broadly, WHO has updated guidelines. The latest updated guidelines dates from December last year, where WHO recommends all pregnant women should be tested for HIV, syphilis, and hepatitis B, at least once and as early as possible. And this July, during World Hepatitis Day, WHO released the first ever global guidelines on prevention of mother-to-child transmission of hepatitis B and guidelines on antiviral use in pregnancy. Now, in these guidelines, WHO recommends that pregnant women testing positive for hepatitis B infection with hepatitis B viral load of more than 200,000 international units per year receive tenofovir prophylaxis from the 28th week of pregnancy until at least birth. In addition, there is a recommendation that if there are settings where DNA is not available, hepatitis B antigen testing can be used as an alternative. Now let's look at why antiviral therapy during pregnancy for the prevention of mother-to-child transmission of hepatitis virus. WHO recommends administration of primary birth dose to all newborns, but we note that studies observe that 20 to 30% of high viral load mothers infect their infants despite the birth dose. And in high-income countries, hepatitis B immunoglobulin, HB, is additionally administered to children of mothers at high risk of hepatitis B transmission. But even with both the birth dose and immunoglobulin, infants of mothers with very high viral load are still at risk of infection. So a need was felt for additional interventions with antiviral drugs. And this new evidence became available, and we have increasing inputs and requests from countries and regions. Here we see that among pregnant women, these are the pregnant women which are the most at risk of transmitting hepatitis B to their babies, and they have high viral load, or they are e-antigen positive. A combined strategy of immunoglobulin plus completion of 3 vaccines plus antiviral drugs can reduce transmission rates to less than 2%. WHO conducted systematic reviews and meta-analysis and evaluations to look at several aspects of the efficacy and safety, but also the performance of the hepatitis B antigen test. And what we also did was to look at the maternal viral load level that for the threshold after which the risk of transmission to the baby increases despite intervention. So let's look at this. A meta-analysis of 129 studies of antiviral use indicated a protective effect regardless of the antiviral use to prevent mother-to-child transmission. Many of them come from China, and tenofovir is the medicine of choice as it has a high barrier to resistance and is recommended by WHO as the treatment for hepatitis B infection. And we looked also at tenofovir's safety, both in infants and in mothers. And we surmised that there was no harmful effects of tenofovir seen, whether this is risk of maternal hepatitis plan, bone mineral density in mother and child, and outcomes in infants. But of course, we note that the data quality is limited. Nonetheless, we are very reassured that tenofovir in both mother and child is safe. Now, The third question we asked was we looked at the evaluations to answer some questions on the maternal hepatitis B antigen test, that whether it can be used to identify pregnant women with high DNA levels, and whether these tests can predict the risk of mother-child transmission. So we looked at the sensitivity and specificity of the test. And the first is the results of the studies to estimate the performance, to identify women with high viral loads. We saw that the sensitivity was 88% and specificity of around 93%. And the hepatitis B antigen test performance to predict the risk of mother-to-child transmission was about 99% sensitivity and about 56% specificity. So overall, the guidelines committee determined that the hepatitis B antigen test can be used as an alternative to the DNA viral load where it is not available. So let's look at the systematic reviews that look at the viral load threshold after which the mother-to-child transmission risk increases despite hepatitis B interventions, such as the vaccines and the human immunoglobulin. And we have identified the viral load threshold to be at a level of 200,000 international units per minute, after which the risk of immunoprophylaxis failure increases. Now let's look at the implementation side. We looked also at value of money and modeling done by partners in Imperial College London. Looked at the different kinds of prevention of mother-to-child transmission strategies, including antiviral drug use. And in many countries, birth dose scale up has the largest incremental impact on new chronic infections and neonatal infections. In other words, we must continue to invest in immunization programs to attain high and very high coverage. Immunization gives the best bang for the buck. And when we look at implementation considerations, WHO had a survey among civil society, pregnant women, and healthcare workers, and there's a whole range of different challenges in the implementation currently to implement these guidelines. And it can range from the inadequate or limited integration of hepatitis B, HIV, and syphilis, prevention of mother-to-child transmission services, lack of capacity to test, lack of infrastructure to test and treat, availability, affordability, costs of drugs, and also for tests, and also for education of women living with hepatitis infection and their families, as well as education for healthcare workers as well. So, but we are on a starting point today, and we can do much more to change this trajectory and find the solutions so that we can reach the true elimination of hepatitis B mother-to-child transmission by 2030. Implementation of the antiviral prophylaxis recommendation will vary by geographic regions because each region is different and certainly each country is extremely different. The implementation will depend on the hepatitis surface antigen prevalence in children and in the general population, service coverage of immunization, including timely birth dose, and the availability of affordable viral load assays, as well as the hepatitis B antigen test, and of course, access to screening and drugs, as well as affordable drugs. So in high endemicity regions, such as sub-Saharan Africa, with suboptimal coverage of infant hepatitis B vaccination. So increasing coverage of the primary hepatitis B host is a priority. It would achieve the greatest impact at the lowest cost. In low endemicity countries, where there is already high coverage of infant vaccination and birth dose, hepatitis B screening and peripartum timophobia prophylaxis in those with high maternal viral load would help further prevent neonatal transmission. So we do have opportunities, and despite the challenges, we believe that it can be done. Countries are already moving forwards to looking into the how of looking at the synergies of triple elimination and getting towards a true elimination of hepatitis B among children. We have opportunities, and there is opportunities to integrate and synergize with the maternal child care programs, and triple elimination is one way. Now, in the Western Pacific region, there is a document, an operational document, which compiles the WHO guidance and recommendations on all aspects of elimination of mother-to-child transmission of hepatitis B. This document provides operational guidance and includes guidance for healthcare workers on management of pregnant women. And it also summarizes some consideration for validation of elimination of HIV, syphilis, and hepatitis B. And with this, thank you for your attention. For anyone who would like to have a copy of this document, please reach out to me or to look at the WHO website of the Western Pacific region. Thank you. I would like to thank the Guidelines Development Group and my colleagues in WHO, as well as the many people who have done this work with us. Thank you very much.
So thank you very much, Dr. Chan. And it was really a wonderful talk. And I think we all were delighted to see that although the tests are very sophisticated and effective tests are available and the drugs are available, but despite that, there are serious barriers for treating women who have the high viremia or are E antigen positive. And this is where the WHO probably needs to develop further more clarifications and easy guidelines. So we'll take, we will have, I think we'll have a lot of questions when we open the floor. So now let me invite Dr. Manal Al-Sayed for the hepatitis B, C, and D co-infections in childhood and their diagnosis and treatment. Dr. Manal is the professor of pediatrics at Ain Shams University, Cairo, and she has been a real driving force for the hepatitis C elimination in Egypt, and has been a champion in this regard. So over to you, Dr. Manal.
Thank you for your kind introduction. I was given the very hard task by IVHEM this year to discuss co-infections of hepatitis in childhood B, C, and D, the diagnosis and treatment. Here's my disclosure. So the key points for my presentation will be the global burden of viral hepatitis B and C in children, global burden of hepatitis delta, the high-risk populations for co-infection, and some case reports for co-infections, how to prevent and how to treat. So why do we need to discuss hepatitis B and C in children and even co-infections? From clinical perspective, they're mostly asymptomatic. And of course, co-infected cases are more likely to progress to liver disease and present with advanced liver disease. From the public health perspective, children are transmitters of infection. DAAs are available, they're safe, highly efficacious for treatment of hep C. Cure of hep C and suppression of hep B would prevent the transmission of infection. And of course, treatment, early treatment is important before high-risk behavior in adolescents. We should consider globalization, immigration, migration, displaced children among high-risk behavior to be high risk for also co-infection. And we cannot eliminate or achieve the elimination goal by 2030, except if we include this population of children. And we should remember that some 2.3 billion children below the age of 18 years make up to around a quarter of the world's population. The global prevalence of hepatitis C of children in 2018 shows a prevalence corresponding to around 3.26 million viremic children. That's by the end of 2018. Some data were actually published data, but some of them were coming from modeling. The highest burden of disease is coming from Pakistan, less so for China, India, Nigeria. Egypt dropped after the national screening program, and the highest prevalence, more than 1.6%, is in Mongolia. The highest predictor of HCV prevalence by age group, for the younger age group less than 4, it's perinatal transmission. 5 to 14, it's iatrogenic, but 15 to 19, which is the adolescent age group, in addition to iatrogenic, also we should look at injection drug use, and that's shown clearly on the right side in some publications coming from CDC and from the US, showing an upsurge of hepatitis C and drug use among adolescents and the whole population, and increased substance use in adolescents, increasing the risk of hepatitis C. How about the global prevalence of hepatitis B in children less than 5 years of age? In 2016, this modeling study looks at 48 million children less than the age of 18 years who are S antigen positive. The majority are residing in West and Mid-West Africa, and some of them in Southeast Asia, particularly in India. The 84% of countries have implemented the hepatitis B third dose, but only 39% of countries offer the birth dose of the vaccine, and that's a huge challenge. The S antigen dropped from 4.7% in pre-vaccination era to 1.3%, but we need to drop it even further to less than 0.5%. The situation of Delta, though, in children is totally unknown. There are very few case reports with either co-infection or superinfection. We only have the global prevalence for the hepatitis Delta in adults, although also there are no good peer-reviewed global estimates according to the Polaris Observatory. They estimate around 24 million S antigen positive individuals who are co-infected with Delta. Of course, the numbers have dropped with vaccination, both for hepatitis B and for Delta. Who are the children at risk of hepatitis C and B and co-infections in low middle income countries? Those undergoing multiple blood transfusions and multiple invasive procedures, those with history of hemodialysis, children born to infected mothers with hepatitis B. They have, of course, a 90% chance of being infected with B if they're E antigen positive. 5 to 7% of those mothers who are C infected can infect their babies, and children with an infected household member and adolescents with high-risk behavior. Some of the data published, or the few cases published, are going to be shown in the following slides, spanning over a 20 years period. This is an earlier epidemiological study from Moscow for 374 children. 195 of those had liver disease, where the rest were without liver disease. Of course, the prevalence of hepatitis B and C was much higher in those with liver disease, 66% for B, around 16% for C for the liver disease population, and around 14.5% for B, 0.6% for C for the non-liver population, and the co-infection rate was 4.7% with Delta virus and those who are HBV DNA positive. In another study from Pakistan, looking at children with chronic Delta virus infection compared to those who were mono-infected with hepatitis B, 48 in each group, 50 of those had undergone liver biopsies, and Delta infection was more aggressive, showing more aggressive liver disease than the HBV mono-infected cases. And when they looked at the differences in terms of age, cirrhosis, splenomegaly, esophageal varices, splenic varices, transaminases, platelet count, and the prothrombin time, INR, and the inflammation liver biopsy, as well as advanced fibrosis in the two groups, it indicated that there was more severe liver disease in the Delta group. Another study from Western Turkey had shown a 1.76% of the co-infection of hepatitis Delta in the B infected cases. And they had shown also a higher fibrosis score in the Delta co-infected population than in the HBV mono-infected population. all the mothers of the Delta cases were chronically infected with hepatitis B. So reiterating again that the co-infection with Delta gives a more aggressive liver disease and a more advanced liver disease. Another retrospective study from France, and this study included many women from African countries, and the study was between 2004 and 2015, looking at 742 HBV infected mothers. Out of those, 3% were co-infected with Delta, and they looked at the 54 children during the study periods, and of those, 36 were assessed and they were given the hepatitis B immunoglobulin. 66% of those were protected, 28% neither infected nor protected, 1 chronically HBV infected, but none were Delta co-infected despite co-infection from many of those mothers. Another study looking at 5 Black African children with membranous glomerulonephritis were co-infected with hepatitis B and C. They could see no difference between those co-infected cases and those who were more infected and presenting with membranous glomerulonephritis. However, the important point in this study was the fact that 24 family and household contacts were infected with either B or C or co-infected. 7 were B, 1 with C, and actually none with both viruses. So probably they acquired the infection through other routes, or their parents had a sort of a stronger or a dominant virus, so the other virus was not diagnosed for one reason or the other. Another one from a resource-limited setting in Yemen, from Taiz Governorate, for looking at 1,484 school children aged 5 to 16 years, and they had schistosomiasis, both schistosoma mansoni in around 21% and around 7.5% schistosoma hematobium, and they could see clearly that the prevalence of hepatitis B and C was high in this population, and the co-infection rate with hepatitis, both with hepatitis B as well as C, and those cases showed more aggressive liver disease. One of our earliest reports looking at the cases also with hematological malignancies, the high-risk population, we looked at hepatitis B and C, and we found that 1/3 of this population was co-infected with both hepatitis B and C, and we could see more aggressive liver disease, and including cirrhosis were reported in the co-infected population, while fulminant hepatitis and death was reported more in the mono-infected population who are receiving chemotherapy, of course, because of severe reactivations. Another study of ours later showed occult hepatitis B in children with hematological disorders and infected with hepatitis C, and overt as well as occult hepatitis B in addition to hepatitis C in the population with hematological malignancies. And we clearly could see that there are core mutations in around 30% of the hematological disorder population, core mutations in 39% of the hematological malignancy population, and we found 1 patient with a mutation in the X region. And this, of course, is a pre-malignant mutation. When we started treatment at that time, because those cases were having severe reactivations of hepatitis B, we started with lamivudine very early in the late 90s. We started to encounter dual infections because at that time we were not doing routinely PCRs for hepatitis C for all cases. So what we've seen is that some of the cases that received lamivudine, at that time we were biopsying patients every 18 months, they had worsening liver histology on lamivudine, and this was associated with a breakthrough with both HBV DNA because of lamivudine resistance, but also for hepatitis C RNA. And if we look at another child who was 13 years old as well, after worsening of the liver histology on lamivudine and breakthrough for hepatitis C and hepatitis B, the liver histology improved 12 months later on interferon therapy when we gave interferon in combination with lamivudine. So that proves that there is a dominant virus always, and there is an inverse relationship, and the dominant virus in the immune competent population is possibly the hepatitis C, but in the immune compromised and suppressed population, it is definitely the hepatitis B. When we looked at the differences and the co-infection population, what accounted for a more progressive liver disease was the number of hepatitis flares related to chemotherapy that the patients experienced during chemotherapy that was associated with a higher grade of fibrosis. So how about prevention and treatment? Of course, for prevention of hepatitis B and indeed Delta, we need to treat mothers in the 3rd trimester of pregnancy if they have high viral loads according to the most recent WHO recommendations. And we need to give the birth dose of hepatitis B in addition to the 2 and 3 other doses in the expanded immunization program. And the recommendations for treatment of hepatitis B, we have very few studies for newer drugs, but what is being approved for children is interferon alpha-2b is approved for children 1 year of age and older, and lamivudine and entecavir are approved for children 2 years of age and older, and we only have tenofovir for those above the age of 12 years. So this is the only salvage we have for those who are lamivudine resistant. Lamivudine is still being used in many resource-limited countries because the generics are available and it has a much lower cost. For hepatitis C, we have those are the approved direct-acting antivirals, and most recently, sofvelpetesvir for those above the age of 12 years, sofribovirin for genotypes 2 and 3, and soflidipasvir ribovirin for 1, 4, 5, and 6. And of course, sofvel is pangenotypic and GP is pangenotypic. And all those are approved for GP only for above the age of 12 and sofvel above the age of 12, but others are approved until down to the age of 3 years in different formulations. Those are the ongoing studies, including sofdaclatesvir from Egypt. There are many studies, including one of my studies that we recently published for pharmacokinetics of sofdaclatesvir. And of course, we have other studies for the sofdaclatesvir coming from Egypt. There is also elbasvir, grassoppervir, and we have the sofvelpetesvir, the studies down to the age of 3 years, and most recently at ASLD, the sofvelvox also studies have been presented. This is also one of our studies that we presented last year for children with hematological malignancies receiving soflidipasvir to prevent HCV reactivations, and 100% achieved sustained virological response. So what we need to do for diagnosis and control of hepatitis C, B, and Delta in children: surveillance, infection control, for prevention, blood safety and injection safety, implementation of birth dose, and of course, universal screening of pregnant women. We need to prevent mother-to-child transmission for both hepatitis B, and that consequently will prevent Delta. Education, awareness, and we have to look at the gaps in research in children because we don't have many clinical trials. For prevention, for treatment, we can use cure as prevention for hepatitis C, viral suppression for prevention for Hep B, as well as Delta. We need to prevent progression of liver disease, as well as stigma and reactivation in the immune suppressed population. And finally, those are the challenges and gaps that we need to look at. We need to address the research gaps. Very few case reports we have on Delta in children and co-infections. We need to prevent mother-to-child transmission and screen all pregnant women, early treatment of women in childbearing age. We need to look at the cost of the tests for hepatitis Delta. They are prohibitive in most of the resource-limited settings, and this is really important. We need to conduct more clinical trials for co-infected cases, particularly for Delta, and we look at the economics of the pediatric formulations, in addition to service delivery for the high-risk adolescent population. And finally, we need to have better screening policies for pregnant women for all viruses, and we need to consider co-infection with Delta, especially in places with high burden in the HBV infected population. Thank you very much.
Thank you, Manal, for a very great presentation and a great data on children, which is obviously much needed and was much required for us. And yeah, it's kind of really, enlightening to see that children are equally affected with B, C, and Delta. And unfortunately, the treatment for less than 12 years is still kind of missing in this population, and there's need to do more for this population. So thank you again, and now we'll move on to the abstract presentations. So the first abstract is the healthcare consumption in the addicted versus non-addicted hepatitis B and C patients from Netherlands. And this shall be presented by Mr. Dan, who is a PhD student. So Mr. Dan, over to you.
Welcome to my presentation. My name is Daan van den Hof, PhD candidate at Radboud UMC in Nijmegen, the Netherlands. On behalf of my research team, I would like to thank Virology Education for granting us the opportunity to present preliminary results of our claims data study on the influence of addiction on healthcare consumption in hepatitis B and C positive patients. There are no conflict of interest. As a result of the route of transmission, HBV and HCV are prevalent among people who injected drugs. Having an addiction may cause barriers to treatment. We hypothesized that barriers such as fears and misunderstandings, stigmatization, and financial concerns would be more common in patients with a history of addiction compared to the general population. This might then result in lower healthcare utilization levels in this subgroup of HBV and HCV patients. To test our hypothesis, we queried the Dutch National Database of Healthcare Claims, CBS in Dutch. We identified all newly diagnosed HBV and HCV infected patients in the Netherlands between 2014 and 2017 and collected all HBV and HCV related healthcare activities and medication prescriptions in the patient's first year after diagnosis. Addiction history was then obtained from mental health care claims data. We grouped relevant care activities by type, for instance, visits, laboratory tests, or radiology. Next, we categorized all patients into degrees of healthcare consumption: low or loss to follow-up, medium, pre-therapeutic assessment, or high, treatment initiation. Loss to follow-up patients are patients with a maximum of 2 outpatient visits and 2 lab tests, no other interventions. Pre-therapeutic assessment category patients had either more than 2 visits or lab tests, or at least 1 abdominal radiological imaging or biopsy, but no treatment. Treatment initiation patients also used HBV or HCV medication. We are still in the process of validating these categories with the help of a panel of hepatitis treatment experts in the Netherlands. We identified 15,017 patients with an HBV or HCV diagnosis between 2013 and 2017. We included 6,680 patients with a new diagnosis. Of included patients, 60% was male. The mean age at diagnosis was 48 years old, and addiction history was present in 13.5%. Surprisingly, we found that patients with a history of addiction were less frequently lost to follow-up or in the low category compared to the non-addicted population, 11% versus 13%. Fewer patients with an addiction had medium healthcare consumption than without a history of addiction, 37 versus 41% respectively. Treatment was also more frequently initiated in patients with a history of addiction, 52 versus 45%. All differences in proportion were statistically significant. Our results show that HBV and HCV healthcare utilization among patients with a history of addiction is better compared to non-addicted patients. This could be explained by the well-organized Dutch addiction care infrastructure. Other factors may also contribute. For instance, influence of the migrant and MSM population among non-addicted patients. Preliminary analysis seemed to indicate an even distribution among groups. Comorbidity may also have an effect, as receiving care for other problems may lower the threshold to engage in HBV or HCV care as well. We are still looking into this. Important to note is that our population consists exclusively of patients that have visited the hospital at least once. So patients that lost the follow-up before referral were not included in this study. Efforts to increase linkage to care may still be needed in this population for primary care. Thank you for your attention. Are there any questions?
Thank you, Mr. Dan. Now I'll invite Mr. Ayana for the second presentation, which is on the occult hepatitis B infection among HIV negative and positive isolated anti-HBC individuals in the eastern Ethiopia. Mr. Ayana is an assistant professor at the Haramaya University. So over to you, Mr. Ayana.
Hello everyone, my name is Desalegn Admasu. I'm from Ethiopia. I work in Haramaya University as an assistant professor of medical microbiology. I also have PhD in medical microbiology. I'll be presenting on occult hepatitis B virus infection in isolated anti-HB core individuals in eastern Ethiopia. When we see the classical serological course, the acute hepatitis B virus infection and chronic hepatitis B virus infection are very much known. Acute hepatitis B virus infection, which may lead to immunity and the presence of anti-HBs in the anti-HB core, which may also lead to chronic hepatitis B virus, are well studied. However, due to lack of multiple seromarkers detection, typical serological profiles are not very much studied. The second profile shows isolated anti-HB core, and the sixth profile shows the absence of all seromarkers in the presence of DNA, what we call occult blood infection. The second profile is known as seropositive OBI, and the sixth profile is also known as the seronegative OBI. When we see the burden of isolated anti-HB core, it ranges up to 20 in low endemic areas and up to 1/3 of the general population in endemic regions. In sub-Saharan endemic areas, up to greater than 50% of the individuals are known to be isolated anti-HB core positive. A recent finding in Ethiopia indicates about 21% of isolated anti-HB core in HIV positive individuals. When we see the hepatitis B virus DNA detection, about 10% is known to be DNA positive in low endemic areas, and the prevalence may also range up to 15 among blood donors. When we see the study setting, we have studied three public hospitals in eastern part of Ethiopia from September 2017 up to February 2018, using comparative cross-sectional study design. In the lab analysis, we have conducted serological examination of surface antigen, anti-HBs, and anti-HB core. We have conducted extraction, amplification, quantification for isolated anti-HB core individuals. The serological result was interpreted using CDC serologic test result interpretation. When we see the results, a total of 306 individuals were found to be isolated anti-HB core, of which 180 were HIV positive, 183 were females, of which 142 were within the reproductive age group. The median age of the participants were also, the median age of was 40. When we see the occult hepatitis B virus infection, the report is limited in Ethiopia. A total of 224 study participants were included in the extraction, quantification, and amplification and quantification, of which 58% were female. When we see the prevalence of occult hepatitis, the overall prevalence was 5.8 and 5.6 in HIV negative and 6% in HIV positive individuals. This figure seems a bit lower compared to previous reports and the recent report in Ethiopia, which reported about 19.1 among HIV positive individuals. Reports actually may vary because of endemicity and the screening methods and the regions used for amplification and detection. When we see the viral load, the mean HBV DNA load was less than 200, indicating true occult. When we see the public health implications in Ethiopia, around 200 units of blood are needed annually. However, the surveys are solely based on surface antigen screening, and of which 52% of the blood transfusion generally in low and middle income countries are given to under 5 children, leading to chronicity. As a conclusion, even though the burden seems lower, OBI may still increase the chance of vertical and horizontal transmission. I would like to acknowledge my home institutions, Haramaya and Ahari, study participants, data collectors, and all supervisors, EPHI virology unit. And I thank you all.
So thank you very much, Mr. Yana. So now I'll ask for the third presentation, and this is on the seroprevalence and associated risk factors for hepatitis B amongst barbers and their clients in 2 cities of Cameroon by Mr. Gupa. He's a nurse in the Cameroon Health Services. So over to you, Mr. Gupa.
Good morning, dear panelists, and welcome to this presentation session on hepatitis B virus prevention. My name is Ngupa Joel Brice, and I am a PhD student in the University of Buea in Cameroon, and I'll be presenting to you on the title Seroprevalence and Associated Risk Factors for Hepatitis B virus infection among barbers and their clients in 2 cities of Cameroon. This is paper presentation number. What motivated us to carry out this study is the fact that hepatitis B virus infection is a serious public health problem in Africa and worldwide. Also, hepatitis B virus is highly infectious and can survive outside the body for several days. In addition, barbers are regularly in contact with the blood fluid of their clients who could develop skin cuts and abrasions during shaving practices. Furthermore, there is few or no data on hepatitis B virus infection among the study group in Cameroon. Hence, we determine the seroprevalence and risk factors to hepatitis B virus among barbers and their clients. Our overall objective was to determine the frequency of hepatitis B surface antigen among barbers and their customers, to determine the knowledge of barbers and customers with regard to hepatitis B virus infection, to assess the practices and risk factors of hepatitis B virus infection, and raise awareness about hepatitis B virus infection among the study population and encourage hepatitis B virus. To carry out this, the following method was used. In step 1, we obtained authorization from the Ethical Committee and the Director of School of Health Sciences and the Divisional Officer of Yaoundé and Douala. The next step, we went to the field and seek for consent from the participant in order to sample blood, which we later on went to the lab, centrifuge, and carry out a rapid diagnosis test. All samples that were positive to the rapid diagnosis test were confirmed using an antibody sandwich ELISA technique, and all our samples were stored in a freezer at negative 180 degrees Celsius. Post-test counseling and sharing of results was done to all the participants, and only those that were positive were referred to the gastroenterologist for follow-up. These are the results that we obtained. We can see here that the seroprevalence of hepatitis B virus is higher among barbers than their clients, and this was in the 2 cities of Cameroon. Also, of the 75.6% of participants who had heard about hepatitis B virus infection, 24.4% had no idea about the mode of transmission, while 63.7% ignored the transmission through barber shaving practices. This is in line with the study of Babacha and R in 2010, who found that this study population are mostly unaware of hepatitis B virus infection through shaving practices, through shaving tools. The higher risk frequency of hepatitis B surface antigen can be accounted by the lack of hygienic condition before and after shaving practices as stated by Wazi and Al in 2008 and poor knowledge as stated by Babacha and Al in 2000. So we are concluding by saying that the seroprevalence of hepatitis B virus is high among barbers than their clients and the general population. Hence, barbers may be at higher risk than the general population. More than 3/4 of the study population had heard about hepatitis B virus infection but had poor knowledge about the mode of transmission since they mostly heard from word of mouth. As perspective, we intend to do this to carry out the same study on a larger population and screen for different markers of hepatitis B virus in order to determine the stage of the infection, either chronic or acute. Also, we intend to use bioinformatics to help to determine cross-contamination resulting from the use of shaving instruments and practices. These are our references, and we want to thank all the actors who made this study to be possible. We thank you for your kind attention.
So thank you, Mr. Gopa, for the presentation. And now we have the should we open the floor for discussion, or we go to the panel discussion? So we'll go to the panel discussion, where we have the first talk from Gavi, the main stakeholder for hepatitis B vaccine. So I would like to request this talk from Deepali Patel, who is the policy head at Gavi. And so Deepali, the floor is yours.
Hi, Huma. Thank you so much for that. I hope everybody can hear me. So at Gavi, what we have our current involvement in hepatitis B vaccination and towards the sort of elimination agenda has traditionally been in the vaccination of infants in the primary schedule. Hepatitis B vaccination is given through a pentavalent vaccine in most Gavi-supported countries. Recently, just 2 years ago, our board approved an investment in the birth dose for hepatitis B vaccine. And so the idea here would be that we would be supporting the introduction and scale up of hepatitis B vaccine in Gavi-supported countries, which are a number of countries in Gavi-supported countries are low and middle income countries. We have about 50 or so countries that currently receive the full spectrum of Gavi support. And so following this decision from our board, our sort of next step would be to develop this program, and as countries choose to introduce the vaccines, they would be coming to us for support, and we would be providing it. Obviously, with this, how things are happening this year with COVID-19 and sort of shifting priorities that we were not expecting, the program hasn't been fully developed yet on our part, so it's a little bit on a pause, but we're hoping to resume it next year. And just a couple of points maybe to say that you know, in line with what we've been hearing over the course of this conference, we found also in our assessment that there's a very high health impact to be achieved from introducing the birth dose for hepatitis B vaccine in Gavi-supported countries. Never mind that this is, you know, a vaccine that's been around for quite a while. There are some implementation challenges in delivering it, and as we've historically sort of invested in and strengthened immunization programs for infants, giving a vaccine within 24 hours of birth is a sort of a different challenge for an immunization program. And it does require strong integration with other sectors within the health system. And so it's also an opportunity not just to have the impact specifically on hepatitis B infection, but also broader health system impact as well across MNCH. And so those were the sort of factors that we thought about as we put forward the investment case to our board. Back to you, Huma.
Okay. Okay, so thank you, Dipali. So that was quick and crisp, and so now we'll move on to the three presentations from three countries, and the first is from Thailand by Yong Pura, who is the professor at the Chulalongkorn University. So, Professor Yong, over to you.
Thank you very much.
We can't hear him. We can't hear him.
Okay, thank you.
Yep.
Okay, thank you very much for give me to talk on our experience on the hepatitis B prevention in Thailand. I would like to share our experience for hepatitis B in our country. In Thailand, 30 years ago, we have the high prevalence of hepatitis B. The prevalence is around 6 to 8%. In the year 1986, we screened pregnant women, and we found that pregnant women get infected hepatitis B carrier around 6%. We did the study to prevention by hepatitis B vaccine. We immunize hepatitis B vaccine into newborn. We divide into two groups. Hepatitis B vaccine at birth and followed by 1, 2, and 12. Compare with the 0, 1, and 6 with and without immunoglobulin. We found that if we use hepatitis B vaccine alone, the efficacy is around 92 to 94%. If the hepatitis B immunoglobulin the efficacy up to 98%. And after that, in our country, we start the EPI program. The EPI program in Thailand, we start in the year 1988. We demonstrate the method of incorporation hepatitis B into the EPI program in two provinces, Chiang Mai and Chonburi. At that time, we start hepatitis B vaccine at birth. At birth, it means that within 24 hours after birth, and follow hepatitis B vaccine at 2 and 6 months at the same time of the DTP vaccine. After that, in the year 1990, we add 10 more provinces have been added into the EPI program. The universal hepatitis B immunization in Thailand was started in the year 1992. And after that, in the year 1994, we start to do the and followed by the hepatitis B, combined hepatitis B and DTP vaccine at 2, 4, and 6 months. We found that hepatitis B in the combined vaccine is the efficacy is the same. In the year 2006, we did the study to compare hepatitis B vaccine at birth, followed by the 2, 4, and 6 with combined vaccine. And the other group, hepatitis B vaccine at birth and 1 month, and 2, 4, and 6 with the combined vaccine. In the hepatitis B carrier mother, we found that if you immunize the delay second dose, the efficacy will less than 3 times of the second dose at 1 month. This is the reason why in Thailand, for the EPI, we start the EPI of the hepatitis B vaccine. We gave the hepatitis B vaccine at birth. If the mother positive or carrier, we add 1 dose at 1 month with monovalent hepatitis B vaccine and follow with the combination of hepatitis B vaccine in the combined vaccine. It means that in the carrier mother, the infant will receive the 5 doses of hepatitis B vaccine. In our EPI vaccine, the combined vaccine start in the year 2008. We did the zero survey in the 2014. We found that in the year 2014, our children aged less than 5 years, the hepatitis B carrier is allowed 0.1%. And the children and the age between 5 and 10 years, the carrier rate allowed 2.3%. And 10 to 20 years, the carrier rate is 10%. When we compare to the adult carrier rate rising up to 6% in the year above 40s. This is we estimated that right now the hepatitis B carrier in our country is allowed 3%. Now in Thailand, we changed from the hyper-endemic country to intermediate endemic country. Right now, from the hepatitis B immunization program with the hepatitis B at birth within 24 hours. Okay, we would like to share our experience. Thank you.
So thank you very much, Professor Yon. And now the second presentation is from Pakistan, and that's to be delivered by me. I'm Huma Qureshi. So let's hear the story from Pakistan. Thank you. Okay, so then we'll go, apparently, I think this story from Pakistan is missing. So I'll move on to the third presentation from Africa by Dr. Fumi Lessi. Fumi is known to all of us. She's the Regional Medical Officer for Viral Hepatitis in the WHO Regional Office for Africa. So over to you, Fumi.
Can't hear you. Dr.
Now we
Lacey,
can
I'm
hear
sorry.
you.
No, I'm sorry, we cannot hear you.
So sorry, I guess that we cannot hear Fiume. While they're trying to connect her, maybe I'll open the floor for questions and answers so that the people who are available can have their questions and we can move forward. So the first question I would like to put to Pauline is about the algorithm for hepatitis B treatment, especially the antivirals. And as you very correctly showed that, one needs to do the hepatitis B viral load, then one needs to maybe check for if that is not available, then the E antigen, and then you go on to use the antivirals. So this algorithm is very tricky and is very expensive, and many a times women, pregnant mothers, are lost to follow up while they are undergoing these tests. So is there a way that, in countries where there's a high prevalence of hepatitis B, that one can start the antiviral treatment and save the babies rather than missing these children who would not be vaccinated, who could not be vaccinated because of so many reasons? Thank you.
Thank you, Homa. That's a really, really important question, because I think today, when we look at the implementation challenges, we see a whole lot of issues. The systems are unprepared, and in many countries, especially in Africa, we barely have the timely birth dose. And institutional delivery rates are far from what they should be. But at the same time, that means that these guidelines and the vision to get to almost an almost zero transmission of hepatitis B, that's the vision that we get at. We have 10 years to do it. And that's what we should try to do. And this opens the opportunity to really look deep and discuss with policymakers and discuss with donors, discuss with the clinical and the public health fraternity, what we can change and what kind of synergies we can do to help to strengthen our maternal child systems, including our immunization systems, obstetrics gynecology fraternity, as well as co-opting the hepatitis fraternity. That means the hepatologists, and where there is no hepatology, training for internal medicine people or physicians. So there is really, some thinking that we can do here and to do much more work here. But the opportunity is there. And the recent evidence shows us that in general, you need to have very good immunization. The birth dose is critical, really critical. And the additional doses will give you the almost full protection for hepatitis B for children. Now, for the subset of women who have very high viral load, then these additional interventions are very helpful. And these additional interventions include the use of immunoglobulin and antivirals tenofovir. There are multiple studies currently going on, including in Asia, in Laos, Thailand, and Cambodia, where they're looking essentially for an HPV-free regimen, where essentially you provide vaccines and for the maternal during pregnancy, you give them tenofovir, but without the immunoglobulin. This is in recognition that immunoglobulin is relatively expensive. It is hard to access. It's mostly unaffordable. Prices range between $50 to $200 sometimes. So I think there's much more that we can do here together. Thank you.
Thank you, Pauline, for informing us that the testing is obviously much more important, because once you test, then it's easier for the decision makers to start the treatments. But then again, the issue remains about the people who deliver at the women who deliver at home in African countries and in Asian countries, where they don't ever visit the health facilities. And there's a high prevalence of HepB in these countries. So I think that there needs to be something more for this group who is unable to reach the testing sites or is unable to afford the testing sites and the tests. Thank you. So, hello everybody. So I heard that Leslie is reconnected with another device. So maybe we can hear from her. So Leslie, over to you. Thank you.
Thank you very much. Can you hear me?
Yeah.
Thank you. Great. So, just very quickly, Africa is very endemic for hepatitis B infection. Today, there are 4.5 million children under the age of 5 years old, down from about 12 million in the late 1990s. So the widespread use of childhood vaccination really account for this significant difference. I'm seeing two images of myself. So today, the 47 countries in the sub-region, they all implement childhood vaccination, but with a coverage rate of about 40 to 45%. 12 countries have hepatitis B birth dose, which means that over 30 countries do not have hepatitis B birth dose. So we have strategies for addressing the barriers and the gaps in birth dose, and one which Patel Dipali had mentioned is the support of Gavi to provide the logistic support for many of these countries to begin to implement birth dose. Right now, even the Africa Union is taking up this political challenge and has a Cairo declaration to support countries in establishing hepatitis B birth dose. Yuma, you mentioned remote villages in Africa and some parts of China or Wipro that do not have access. So part of the challenges we have in many countries in Africa is the lack of the policy and guidelines for hepatitis B birth dose, the weak health systems, really, and of course, the challenges of HIV, TB, and malaria are competing epidemics in our region. In many countries, hepatitis B birth dose may be available in the private market, so not part of the public health system, and less than 30% of the people can access these services. It is notable that now, with WHO working on defining elimination, validation of hepatitis B and C as a public health threat, with the impact target of 0.1% of hepatitis B surface antigen in children less than 5 years old, this is going to be a tall order for many African countries to reach. Right now, there are 2 countries that have 0.1% in less than 5 years of age. So there is the path to elimination, which is mainly for African countries and countries with high prevalence, where programmatic targets will be used to evaluate the level of response. And this is phased, and it's going to be like the HIV response, where there is a path to elimination, using programmatic indicators like hepatitis B birth dose and childhood vaccination, and later on coverage of women in antenatal care for hepatitis B testing. I think I'll just wrap it up right there, and thank you very much for the opportunity.
So thank you very much, Laitsi, and this was really very informative. So we have a very short time for discussions, but still I would try to catch up with most questions that come to me. So for Manal, there were these issues that people were asking about the Delta virus infection, which causes a suppression of the hepatitis B and the HBV DNA. So many a times one can fall into that trap of a low viremia. So how do you tackle that issue?
Yeah,
Manal?
that's an
Yeah.
extremely difficult question in pediatrics, I think, because we rarely, I've seen only maybe 2 or 3 Delta cases over the past 10 years, and we have a very low prevalence in Egypt. But I know that in Pakistan you do have a higher prevalence of Delta. Mongolia, they have a higher prevalence of Delta, and the key at the end of the day is just prevention of hepatitis B. And I think, as Pauline mentioned and as Fumila mentioned, that birth dose vaccination without HBIG, and I really would commend you for that comment, Pauline, because we do not want the HBIG in any policies or guidelines, because it's really expensive, it's not available, and in resource limited settings, it's impossible to get the HBIG. So for Delta, my experience with co-infection is very small. I have a larger experience in the HBV, HCV co-infection, because I have a huge cohort that's co-infected because of either multiple blood transfusions or of cancer chemotherapy. But I believe that the key is prevention and is the birth dose. And I would like to add also that we need not only policies and guidelines for internists and hepatologists and healthcare providers, but we have to look into the obstetricians, please, because their information about hepatitis B birth dose is very small, about screening of pregnant women. And we need to go into societies and associations of gynecologists and obstetricians and make them aware of the importance of screening of pregnant women. Not only pediatricians, but obstetricians as well. And I think that's something that the WHO as well needs to work on, and need to link the obstetrician societies with WHO to improve awareness and to integrate this kind of guidelines and screening guidelines within their own guidelines that they discuss in their international meetings.
Yeah, so thank you. Yeah, Manal, you're very right that, apart from the gastroenterologists and the hepatologists who are very well aware of the do's and don'ts, unfortunately, the gynecologists who are the prime carers of the pregnant mothers are not at all aware of the testing and the treatment guidelines. Yeah. And I think the other thing we need to probably push very loudly is the hepatitis B vaccine is a very heat stable vaccine. We all know, and still we hear that a lot of people are still kind of making a hue and cry that we don't have the refrigerators, so we can't take the vaccine to the grassroots level. So I think this also needs to come out loud and clear that this vaccine is quite safe and can be taken out of the cold chain.
I would like to add, I would like to add just one small thing, that we do not have a good treatment for children with hepatitis B, and we still do not treat properly children with hepatitis B, either because we do not detect them early, because some of them have horizontal transmission, not necessarily from mother to child, but they have horizontal transmission, especially in the first few years of their lives. And also the other problem is that we still think about the immune tolerance, while all the classifications have changed now, and the children do not fit into the new classifications in the adult population in the majority of cases. So we are stuck as pediatricians on whom to treat and whom not to treat for the pediatric population. I think we need more trials. I need to expand on clinical trials, and we need to think a little bit outside the box. We've seen immune tolerant children with active disease by liver biopsies, and I think we need to work together on a global level also to eliminate hepatitis B and Delta, of course, in children, not only prevent hepatitis B.
Yes, yes, sure. Thank you. So now I have one question from for Gopa, and this is they're asking about the infection of HIV and hepatitis B in the people who are going to the communal barbers and the razor through the razors. So Gopa.
Right. Thank you very much. Thank you very much for this opportunity, and thank you for your question. If I heard you very well, you are talking about the prevalence of HIV and hepatitis amongst barbers and their clients.
Yeah.
All right. Fortunately, I don't know if there is a study that have been conducted to determine the prevalence of hepatitis among barbers and their clients before the one I conducted. And as far as HIV is concerned, it's true I've not yet seen studies that have been conducted to determine the prevalence of HIV amongst barbers and their clients. But nonetheless, the study which I conducted, I came out with the prevalence of 12.6% prevalence of hepatitis B virus among barbers and their clients. The prevalence was 12.6%. So I did not work on the co-infection of hepatitis B and HIV.
So
I don't know if, yeah.
Yeah. So okay. Thank you for this information. And apparently, I don't see any questions in my chat box. And maybe we'll ask Fumi to throw some more light on the hepatitis prevention in high HBV countries and in countries where there is access and affordability issues, especially with the immune globulins and the testings.
Thank you very much. Two quick things. A recent case series from Africa on liver cancer showed that nearly 10% of that liver cancer cohort was under the age of 30 years. And of those 10%, the people under 30 with liver cancer, over 90% of them had hepatitis B. So it's just to strengthen what Manal has mentioned about testing and treating children and adolescents, because it is these children and adolescents that go on to develop cancer. So as we're struggling to treat HCV in children, we need to take a closer look at hepatitis B in this population. Secondly, in terms of HBV and HIV co-infection, there have been multiple large studies in Africa, including the HIV impact assessment in Cameroon, in Nigeria, in Uganda, that often shows a similar HBV prevalence in HIV positive and HIV negative populations. Usually, the HIV positive may have a minimally higher prevalence, but it's usually not statistical significance. And of course, this is attributed to the early hepatitis B infection transmission in this part of the world. So in terms of access to drugs, access to commodities, that has been a real challenge. In a country like Uganda, that has a large hepatitis B program, over 5 million people have been tested for hepatitis B, and they have a strong program in place. But there are various gaps, and they are working on closing those gaps in terms of treatment of hepatitis B persons. In terms of immunoglobulin, I am happy with what Pauline has said. Immunoglobulin is unaffordable in a continent where 12 countries have birth dose, where birth dose is a challenge. All right, then immunoglobulin really is very unaffordable to most. And I have seen many healthcare workers make patients sell everything they have just for the immunoglobulin. So there's a need to teach healthcare workers, not just gynecologists, but basic healthcare workers and nurses and community health workers. In fact, there's a need for increased awareness in the population because less than 10% of the African population are even aware of viral hepatitis. So there are multiple challenges which, with strategic planning and commitment and funding, can be overcome. Also, looking at service delivery and integration with pre-existing programs like with the HIV program. That is one good way of going forward in the triple PMTCT for HIV, hepatitis B, and syphilis. Thank you, and over.
Thank you, Femi. And I think now we are also running to our end of the meeting. And I'm really very thankful to all the participants who have been giving us really good information, good data about the disease, its prevention, and its management. So, right, so we'll come to the end of the meeting, and thank you very much for being with us and for joining us at the IVHM 2020 meeting. Thank you.